Well, good afternoon to those of you in the eastern U.S. or in the Midwest. Good morning to you in the Mountain and Pacific time zones. Welcome to the fifth and final webinar in our series on opioid treatment provider, or OTP, care coordination. Today's webinar will focus on bringing it all together, practical ideas for implementation. These webinars are brought to you by the SAMHSA Behavioral Health Information Technology and Standards Initiative. My name is Alan Vogel, and Associate Scientist with APT Associates, part of the BHIT team. Just as a reminder to our listeners, a PDF of this PowerPoint presentation will be emailed to all registrants who signed up for this webinar afterwards. This webinar is being recorded and will be posted to SAMHSA's YouTube page at www.samhsa.gov. Please note that all lines are muted. You can submit your comments via the chat box feature typically found in the lower right portion of your screen. And we will save all our questions for the final 15 minutes. This is a 90-minute session, so we will allocate our questions to the very end there. And one final note, following the Q&A, we will have some closing remarks from our SAMHSA representative. So, with that, we have two speakers lined up for you today, and it's my privilege to introduce the first speaker, Dr. John Brooklyn. Dr. Brooklyn is affiliated with the University of Vermont College of Medicine as clinical faculty and has been involved with research on cocaine and heroin treatments, including buprenorphine, for decades. As a family practitioner who specializes in addiction medicine, his work includes integrating substance use treatment into primary care by using a learning collaborative strategy and using innovation to transform the delivery of treatment of opioid use disorders throughout the state of Vermont and throughout the U.S. John has been a presenter in this series clear on. So with that, I introduce to you John Brooklyn.
Thank you, Alan. That was a very nice introduction. I appreciate it. Hello to everyone, and thanks for listening in. I guess I had the daunting task of trying to help people understand what it took to put together a model that we use throughout the state of Vermont. And what I would like to remind folks is that the hub and spoke system is really designed to integrate substance use disorders into primary care, and it provides office-based supports for those primary care providers and a referral network for more complex cases, really mirroring that of any other chronic disease that we deal with in medicine. So I have about 30 slides. I'm going to take about a minute on each one, and I'm going to try to give you as much information as I can, but I'm not going to talk about what the hub and spoke model is. I did that last time. This is more about how to actually implement such a model if desired. So what I think it's important to do is consider what's needed. So I'm going to take you through the different steps that I think are important in order to put such a program in place. First would be, what is the need for opioid use treatment in your state? What can we do to eliminate stigma? We need to have an agreement that agonist medication is the cornerstone of treatment of this disease. We're not talking about abstinence models. We're talking about the use of medication, methadone, buprenorphine, and naltrexone. We're going to talk about workforce development, retention, and education, which is so critical for this. We're going to touch on financing and funding. We're going to talk about community involvement. We're also going to discuss a little bit of the concept of leveraging political power and governmental will. And then we're going to add in the criminal justice system, which I think will be a nice segue to Linda's presentation, which we'll spend more time on that. So one of the key things to understand is that all states are probably grappling with what we have dealt with in Vermont. And we looked at what we call the perfect storm, where we had increasing rates of opiate dependency. We didn't have enough treatment. We had long waiting lists, especially in some of our larger clinics. We had high healthcare costs for people that were not in treatment, all the issues around criminal justice. In some cases, we had people who were on buprenorphine or were on methadone and were having poor outcomes because of the way that the practices were being structured. You obviously have funding silos and program silos. A lot of OTPs around the country are set aside from medical practice. There's no real integration, collaboration. And then you often don't have the key health providers. You don't have large medical systems often involved with treatment, even though they may be getting patients into their tertiary care hospitals with endocarditis, osteomyelitis, all the disorders that can occur to people who are injecting drug users. And then you have the obvious isolation, stigma, and lack of a voice for the community with addictive disorders. So we had all these things in play. And up in the upper right-hand corner, the Blueprint for Health is our healthcare authority that looked at opiate use disorder as a chronic disease and determined that it needed the same level of care and coordination as all the other chronic diseases such as diabetes, heart disease, etc. So if you look at the model, this is actually kind of the stages of transformation. So the care as usual, as many places in the country, you may have OTPs that prescribe methadone. Perhaps they have some integration into the healthcare system. Then you have your office-based providers. Some are cash providers, some are insurance providers. And at that time in the state, in 2011, we had 5 regional OTPs throughout the state. We had about 125 doctors prescribing buprenorphine. The concept was to try to create these health homes where we were looking at how do we create a system where the OTPs can also integrate care a little bit more, and what do we do with our OBOT providers, our office-based opiate treatment providers who are mainly buprenorphine providing. What we looked at was this section of the Affordable Care Act that allowed for health home coordination, and you can see just below in the purple the 6 different types of health home services that could be provided. And so if you give to the OTP the staffing, which was about 6 FTE nursing and medical assistants per 400 patients, or in the spokes, what we call the medication-assisted treatment team, a full-time registered nurse and a full-time master's level clinician for every 100 patients, you create what we call the hub and the spoke, both of which had enhanced services to be able to build to these additional coordinated services, and we call them advanced care practice and community health teams, known as the hub and spoke. So that transformation was necessary to occur in order to make this integrated model happen. You can see here a graphic picture of the state of Vermont. We're relatively small. We're the second to most rural state in the United States. Burlington, Vermont, which is the largest city, is 35,000 people. Chittenden County is about 150, 200,000 people. So it would mirror a medium-sized city or very rural areas throughout the country. Newport has 5,000 people. So these orange squares represent where the OTPs were located. And what we did is we took and created each of the orange squares into a hub. So in Rutland, for instance, where the arrow is pointing, you may have 20 providers of buprenorphine in that area. They would all refer to this particular hub if they had issues where the patient needed a high level of care. And so we regionalized this just like you would for any other chronic disease. If you have an infectious disease specialist here and you have a person down here with recalcitrant pneumonia, this is where you send them. So what I think is critical for states to look at, and I've argued this, is that we may have actually underestimated the amount of need for the treatment of opiate use disorder. It's estimated right now that about 2.4 million Americans need treatment, and that's about 1% of the population. What we discovered in Vermont is that we currently have 1.6% of our adult population on opiate agonist treatment. There's about 8,000 people on either methadone or buprenorphine out of 500,000 people. So if the federal government has estimated 1% of the population, and we in Vermont are already seeing 1.6% of the population on OAT, and we think that that's only 50% of the unmet need, then that would mean that we may have to take 1% as the low number and even 2 or 3% as the number needed in the state. So what that means is that as a state planning authority, you would need to look at your population over the age of 18, take 1%, 2%, 3%, and use each of those numbers as endpoints, the number of people that you would need to actually treat with either methadone or buprenorphine, and from there you can create your system based on the need. So oftentimes to calculate these numbers, the state has a registry of the number of people in methadone programs. You can look and see whether those are at capacity. You can look at your prescription monitoring program or some other metric the state opiate treatment authority may have to see the number of people that are actually on buprenorphine. And then you can calculate the current number of waivered providers. And you now have nurse practitioners and physician assistants who can also prescribe who should be in that mix. And you list by their waiver cap. You may know who's at 30, who's at 100, and who's at 275. The difficulty is that most providers, and we found this in Vermont, do not practice anywhere near to their current capacity. So you may have a lot of providers who are waivered, who maybe are treating 1 to 3 to 5 individuals. And the goal would be to say, well, what would it take to get that provider to practice to the limit of their capacity? So if you had 100 providers who were treating 3 people each, you've got 300 patients. But if they were to treat 30 patients, you'd be at 3,000. And so it's really looking at the current capacity in the system more than actually who's actually prescribing. And then you'd also want to look at underserved areas. Are there areas in the state where there are no providers, or there's maybe just one provider who's very heavy at 200 or 220 and need to supplement that area with additional prescribers? The second thing to really consider is stigma. And I think that the biggest obstacle we have throughout the country is this. We have to get agreement that opiate agonist therapy is the cornerstone of treatment. I think we also have to decide that slots in outpatient programs are more important than slots in residential programs. People have to come to the recognition of harm reduction versus abstinence, that you may not have a perfect picture of complete abstinence, but you're reducing harm, especially in the era of fentanyl overdose and the opioid epidemic. Any day that someone's not in treatment could be a fatal day. We also think it's important to leverage your addiction experts in the state to talk about the evidence behind methadone and buprenorphine, and not necessarily favor naltrexone over them, but to make sure that all 3 medications are talked about and advocated for. And then also to engage people in long-term recovery to share their stories of their successes, because I can tell you that the hearts and minds of people who are opposed to opiate agonist treatment can often be won over by listening to people share their stories of success. Then you have the issue again around stigma of the barriers of providers. We have had many surveys, national surveys, published data to look at why docs choose not to treat this as a chronic disease or even as a treatable disease. And this is just a list of the different things that have been encountered. So when we thought about the hub and spoke system, we thought, well, what can we give to primary care providers to help them deal more effectively with this? And so if we offer staffing, if we offer training, the idea was that you begin to reduce the barriers so that docs would be willing to take on patients and see the success of their patients, and therefore begin to treat more and more people if possible. And the other thing is that the OTPs were often isolated. We definitely wanted to bring them into the mainstream of medicine so that people were integrated into general medical care who were at OTPs. The next step we had, and I think the key thing just to mention at this point, and this is further down, is that the creation of the hub and spoke system really can't occur until you have an active prescribing base for buprenorphine. Because when people come into hubs, which are OTPs, and they have to dose every day with either methadone or buprenorphine, those slots can quickly fill up. And unless you can transfer people out to spokes where they would continue to receive buprenorphine therapy, the whole system backs up. So while I appreciate that many states have pretty good sized OTPs, it's really building that network. So the way that we built the network in Vermont is we offered free waiver trainings to providers, and we actually paid them for their time to participate. We created incentives to prescribe buprenorphine. At one point, we had a roster where you would keep track of the people that you were treating, and you would build a state, and it was an enhanced benefit to doing that. We have almost no cash clinics in the state. all of our clinics need to take insurance, and I know that there are some states, I think the state of Virginia actually spends a lot of time trying to mandate that buprenorphine providers take insurance, but that will help significantly. The model out of Johns Hopkins by Ken Stoller, which is the co-op model, really talks about having regional mentors. So if you have experts in your area and you can't quite create a statewide hub and spoke system, you at least need to engage the addiction experts and mentors so that physicians feel more comfortable to prescribe. We've had statewide conferences on substance use disorder. We bring in experts to speak. We want to have evidence-based practices. And we also would encourage the nurse practitioners and the PAs to be wavered because many times they have a bit of a mission to take care of folks who are struggling, not to say that docs don't, but they sometimes will have a little bit more time and they should be engaged in that. And then because I'm a practicing doc at a federally qualified health center, my heart seems to live in FQHCs. I believe that FQHCs are really well positioned to be spokes. Those are federally qualified health centers, well positioned to be spokes because of the amount of resources that they have. And much of the mission of an FQHC is to take care of the underserved. So I think it's very important around the country to have this particular type of practice really engaged in the treatment of opiate use disorder. The additional creating a nurse model out of Massachusetts. There's a great model by Colleen Lavelle to support and help treat opiate use disorder. Our nurses, our registered nurses who are in all the spokes take a lot of the time and pressure of the day-to-day management of opiate use disorder, if there's prior authorizations that are needed, if there are urines to be collected, if there are prescriptions to be refilled, all of these things can be dealt with by the registered nurses, helping the providers. We also created mentorships at our programs for docs to come, nurses to come, social workers to come and learn about the treatment of opiate use disorder. The nursing schools will send nursing students to expand their curriculum. And then we also try to get clinicians who are abstinence-based to come to our programs to see people that are on medication so that they can understand that this is a collaborative treatment that has medication as a big part of it. And the medical home model, which I really encourage people to think about, is team-based. It's not just the doctor with a waiver. It's not just people go to the methadone clinic and get a dose. It's a team, and this is a disease that requires a lot of care and a lot of coordination, especially with the disruptive lives that a lot of people have. And a team-based approach seems to work really well in terms of getting people to stay in treatment. What about workforce retention? You know, a lot of times you may have a practice that's large and maybe a doctor retires, dies, or moves away. What do you do with all those people? So one of the things that we have is because there are hubs and other spokes, people can be transferred to other practices. They don't lose their care. We have to be careful about payment structures. Sometimes the staffing from a hub, which perhaps were counseling and nurses, perhaps the reimbursement wasn't very good, and when they could get a job as a spoke staff, they often would leave the hub. And so looking at the payment structures for paying for those, we'll talk about that in a few minutes, is critical. As I mentioned, a strategy for a provider who retires, loses his license. Hubs can absorb these folks temporarily, or having a more diverse workforce will allow that to happen. I'm an advocate, as many others are, making sure that medical schools and residency programs are offering training around methadone and buprenorphine, and our medical students at the University of Vermont our residents in the University of Vermont in family medicine and internal medicine all are offered buprenorphine waiver training. The OBGYN residents, psychiatry residents also get that. So I think it's key to advocate the medical schools, residencies, and nursing and PA programs to offer that training. And then obviously trying to establish some fellowships would also help. The MAT team, as I mentioned earlier, the nurse, the full-time equivalent nurse, and the master's level clinician are the provider's safety net. They will help the provider deal with positive urine screens, what to do if a patient is disruptive. These are additional resources that make a huge difference in a provider continuing to want to provide this kind of service. We published a paper in the Journal of Substance Abuse Treatment on our learning collaborative. Because physicians take a training. It's an 8-hour waiver training. They really don't learn how to become specialists or adept at taking care of addictive disorders. So the Learning Collaborative was a free training that was 6 to 8 sessions over the course of a year or two that helped increase knowledge around things such as positive urine screens. What do you do about behavioral issues? What about engaging people in therapy? What do we do about convincing patients to consider naltrexone? So these were all structured classes run by faculty from either Dartmouth or the University of Vermont, and I think it's been shown in many other diseases to be very effective, and I would encourage learning collaboratives to be enacted in your state to increase the training for folks. These hubs are considered centers of excellence. They're all staffed by either board-certified addiction or board-eligible addiction physicians, so we can take care of anything that's referred to us from a spoke, whether it be alcohol, cocaine, stimulant, misuse. We also have a treatment need questionnaire that we developed that helps people decide whether they should be going to a hub or spoke depending on their level of severity. The OBOT Stability Index is another document that we can provide so that the spokes can look at a patient who's coming in and decide if they need to be referred to a higher level of care. We created medication-assisted treatment rules that were applied to all hubs and spokes in terms of how much time could go by before a behavioral health assessment needed to occur, how frequently urine testing should be done, what the response should be to positive urine screen. And we aligned that with both the Data 2000 and 42 CFR Part 8 so that we did not have disparate guidelines, they were all unified. And then we actually wrote buprenorphine prescribing guidelines as a free resource so that if a physician had an issue and they wanted to know what to do or they wanted a sample contract, whatever it was, they were freely available. Other things to consider in terms of workforce education, as I mentioned, is local experts. The ECHO model has been used in many places of the country, and I think that's a great resource for long-distance learning and support. There's the National Physicians Clinical Support System that is available free of charge to any buprenorphine provider in the United States. And then the MAT workforce in each of the counties, the collection of spoke providers and MAT teams would get together and have monthly workforce meetings to look at how they were going to integrate their services within the county. So how do you pay for this? Well, Vermont was a Medicaid expansion state. We actually have had pretty good benefits over the decades. We had to get a state plan amendment to allow for the funding of the hubs and the spokes. We have commercial insurance support for community health teams for diabetes and hypertension and asthma, so it wasn't very hard to leverage that also for opiate use disorder. We've seen a significant cost savings in the near term. We've got some data that's available to show about a $4,000 or $5,000 per patient per year difference savings for people who are actually on agonist medication versus those with the diagnosis of opiate use disorder who are not in treatment. We have reduced significantly our overdose and death rate. We have one of the lowest rates in the country. A recent CDC article showed that we were in the top 5 lowest in the United States, and we believe a lot of it has to do with access. And so when you talk about financing, you talk about funding, to me, that's an end that you're trying to avoid. And then all healthcare plans will cover buprenorphine with no limits on duration, as is seen in some states. So what the core elements were is that the hubs are based on a monthly rate, and that monthly rate is enhanced if there's a health home service. So let's say the cost of doing business is $400 a month. Your basic rate was actually pegged below that. Maybe it's $350. So if someone comes in, gets a dose of methadone every day and doesn't see anybody or do anything, you get a basic rate. But if they meet with their counselor or they meet with a care coordinator and then they have enhanced service, you might get paid, you most likely would get paid the enhanced rate, which is about $500. So the incentive is the carrot is there to have you coordinate care and get an enhanced rate. The services of the case manager and the clinician were provided free of charge to the spokes, and they will visit the practice. So if you have 20 patients, you'll get 0.2 FTE. If you have 200 patients, you'll get 2 FTE. So it was payment was based on need and enhancing rates. I've mentioned this already, I'm not going to review this, but the ACA 2703 Vermont State Plan Amendment is where we pulled the funding. It was a 90-10 funding split in the spokes and 30% in the hubs. After 8 quarters, we had enough of a savings shown that we've actually become a self-funded system now in the state of Vermont. We no longer draw down funds as we were. The services were listed earlier. These are one of the 6 services that needed to be provided either in the spokes or the hubs by one of the care managers in order to draw down the additional funding. The other thing to point out is that this required high standards. So NCQA primary care medical home, we have over 86% of all of our patients with opioid use disorder as of 2016 had a primary care medical home. All of our hubs are NCQA level 2, and one is actually level 3, which is the highest accreditation level you can get in the United States as a specialty health home. And then we've had our assessments looking at it to look at adherence and cost impacts, and they have been favorable thus far. So what are the challenges to system development? You really need to have some consistent vision between state agencies, particularly our funding agent and our Department of Health agent and our pharmacy benefits. So getting all those parties to the table together and agreeing is very important. You have to understand all the regulatory structures and then determine the payment mechanism. One of the things that happens in the hubs is that the hub rate is pegged towards methadone being the standard of care. If the hubs provide buprenorphine or naltrexone, they're paid the additional amount outside of that case rate that I mentioned. So that enhanced rate of $500, you add to that the cost of buprenorphine and naltrexone through a funding mechanism through the Department of Vermont Health Access, our Medicaid authority. So the medication is not absorbed in that case rate, it's above that case rate, and that was worked out in order to be able to pay for it. Let's see, I think I've mentioned this. Yes, and then the other part to mention is that CSAT in 2013 removed the time and treatment requirement for buprenorphine. So we were able to give people in the hubs advanced take-homes as opposed to methadone, which is a bit more restrictive based on that. So people can come into a hub and not necessarily have to daily dose on buprenorphine. We may daily dose them initially, but we can give them take-homes a little bit faster as long as they qualify. So these are some of the action steps that need to be considered to address the issue in each state. I'm not going to go through them, but essentially it's prescriber education, how do you track, how do you enforce, how do you dispose of medication, and then what about the recovery community? We have a lot of regional recovery centers, we engage them in the treatment, and we want to bring all the players to the table. So it's really important to bring all the different players to the table. You can't operate without having a few people involved, and having physician clinical champion leadership is very, very important. The lessons learned is it's important to design the model before beginning to pilot it. Getting willing providers to do the work is very important. Making sure the relationships continuously get built is critical. So if you have a region of your state that you have a committed group working together, they sit down, they work all the different connections they might have with their mentors and perhaps the OTPs, but it's these relationships and keep going back and building them, and it's so critical to making this kind of model work. There was a movie that was produced in the state of Vermont called The Hungry Heart. It was about a rural community struggle and a doctor that made a difference. That movie toured the state, and it made a huge difference in getting communities who were previously resistant and physicians who were previously resistant to treatment to agree that medication-assisted treatment was very important. We also have a weekly, in the largest county, ComStat meeting with the police chief, the mayor, the treatment providers. They meet every week, and that's pretty important, I think, in a lot of areas where people struggle about what to do. We have what's called a CHARM group, which is a Children and Recovering Mothers. It's our pregnancy and parenting wraparound group that meets monthly to talk about cases in the community with coordinated care. And then we do have connections to all the recovery centers in the state. We were lucky that our governor in 2014 devoted his entire State of the State address So he didn't come to that overnight. He had a decade of being exposed to the importance of medication-assisted treatment, and having been in the Senate, seeing testimony, hearing testimony, made a huge difference in his transformation to becoming a champion of treatment of opiate use disorder. We've had a significant reduction in the emphasis on residential programs, and that's looking at data and outcomes. Our local law enforcement have a rapid intervention program to direct drug offenders to treatment rather than criminal justice system. And all three of our drug courts support opiate agonist treatment, which is very, very important. We've had many conferences, and then we had actually intense pressure on our largest medical school, our only medical school, our largest medical center in the state, to develop a treatment network that really kind of tipped the balance in terms of getting the increased number of waiver docs, that it took political pressure to get the providers to actually begin to prescribe buprenorphine. And then I think the last slide I have, or the last two slides, is in the criminal justice arena. We believe drug courts need to embrace opiate agonist therapy. We have an annual conference for the judges in Vermont, and they learn about treatment. We now have all our jails are starting people on buprenorphine while people are incarcerated. People are maintained on either buprenorphine or methadone when they are incarcerated. And we work to get inmates released, starting on treatment before they leave. And I would encourage states to think about inducting people while they're in prison onto medication and linking when they get out. I made my time to the T. This is my contact information. Thank you so much for listening.
Thank you, John. Thank you very, very much. And just a reminder to our participants, if you do have a question, you may type it into the chat box feature in the lower corner of your screen. Well, with that, let us move on to our next speaker. She has joined us previously in this OTT webinar series. Also from New England, we have Linda Hurley. Linda serves as CEO President of Kodak Behavioral Healthcare, located in Cranston, Rhode Island. She has worked in the substance use disorders treatment field for over 25 years and became Kodak CEO President in 2016. Under her leadership, her agency was the first OTP in the nation to receive Health Home certification and was the first Rhode Island OTP to be designated as a center of excellence. She has consulted for state and federal agencies, including SAMHSA. So, Linda Hurley, let's hand the microphone over to you.
Thank you, Alan. How does this sound, okay? Yeah.
Yes, we do hear you.
Okay, good. I had a little trouble there for a minute. Thank you very much. And it's been an honor and certainly a pleasure to be presenting on these three innovative programs in care coordination in Rhode Island. As John mentioned, this is the fifth of the series, and we have provided an overview of these programs as well as the programmatic needs assessment, and some finance and regulatory considerations. So with that being said, I'm going to speak very briefly to those, and we'll move through each of the three programs. And I'll just do a couple slides on what it is for those of you that may not have been participating in the previous presentations. Let's see. So we will go from there. So the three models of innovative care coordination are enhanced medication-assisted treatment in the Rhode Island Department of Corrections, which it began in 2015, but the medication-assisted treatment in Rhode Island has been in place since 1994 in one form or another, with methadone only as medication, and until very recently, which we had talked about previously. The second model of innovative care, which John spoke of comprehensively and beautifully, so I won't spend a lot of time on that, are the opioid treatment program health homes, which were initiated in Rhode Island through a state plan amendment as well. in October of 2014. And then the Rhode Island Centers of Excellence for the Treatment of Opioid Use Disorders is actually very, very similar to the hub and spoke model, with the Center of Excellence being the hub. Purpose model, very exciting. Many of you may have seen it. It seems to be getting a great deal of press at this point because of our outcomes, which are remarkable, and because of the ability to replicate those. So one was, I love this quote, what once was the barrier to recovery is now the intervention, which means it used to be when people were incarcerated, any treatment that they were having in the community was then disrupted. And if they weren't receiving treatment, they went through uncomfortable withdrawal and really didn't get much support. Now coming to prison is going to actually become an intervention. So what makes the program a little bit different is that all 3 FDA-approved medications are available to inmates in need. So whether it's a buprenorphine product, methadone, or naltrexone product, all 3 are available to inmates in need, regardless of sentence status, which is really important because someone can be simply being held and what would be equivalent to other states as in jail awaiting trial. They receive what they need. So regardless of sentence is remarkably important. One does not have to be sentenced and in prison for a significant amount of time. Then it's through a co-located OTP on site at the prison. So Kodak, as the vendor, was very fortunate to be able to initiate those. And so we have a dispensary for those of you that participate in the administration of the provision of care in OTPs. We're right there, and it's wonderful because it's real-time response. And then the last piece is that we also have discharge planning available in this program that really does allow for intensive, seamless coordination of care directly to not warm but hot handoff to reentry services. The goal of the program, decrease mortality. In 2015, 24% of deaths in Rhode Island, opioid overdose deaths in Rhode Island occurred in the population that had recently been released from prison. In 2017, we saw a 61% decrease in overdose death. I have really emphasized this in all the presentations. I think it's critical to see that this can happen. We can see this kind of change, and it's fairly simple. It's fairly simple in terms of mechanism. I just included this slide again. I thought it was important to see. As we look at the implementation, you can see that this was a very short timeline for everything that had to be done. So the following slides are going to show how we moved along that timeline. So when you look at the right here, I won't spend a great deal of time on this, but the workflow was actually the piece that allowed us, we saw what we wanted to do. We identified what needed to happen with a great deal of complexity because of the correctional environment in which the services were being provided. It wasn't simply that we were sitting down and defining, we want to do this, how much money does it cost, let's go. We had to really look at how do we do each of these functions? How do we screen upon commitment? How do we get people the help they need within 24 to 48 hours in a prison system? So it really, the primary, in this particular program, when we looked at workflow and implementation, systems integration was the primary principle, the primary challenge, and the primary gift that we needed to pay attention to in order to successfully meet our goal. So we had to integrate the mission, safety and treatment, retribution versus rehabilitation, and the way to do that, and I will speak to this over and over as well, is relationship. We needed to include all stakeholders at all points of program development and in resolving challenges, which was successful and continues to be a challenge, but it was successful. The next piece, once we determined that these are the functions that need to occur to meet our goal, was what kind of staffing would we need to do this? And again, taking into account the corrections environment. And the third bullet is important here because we needed to look at what was happening in the Department of Corrections, medical, finance, security, and then what happens as the vendor? What happens if Kodak needed to bring in our doctors, our nurse care managers, our counselors, and our discharge planners? How do we integrate this? Next in the action steps, which we had underestimated, is it's what we needed for folks to be able to fill these positions in a way that was going to allow them to be effective. So individuals needed experience in correction settings if possible. It takes a long time to learn that culture. And they also need to demonstrate not just professional maturity or experience, but interpersonal maturity. The individuals that would be hired to provide the service in the prison system really do need to be an ambassador for the program. So that takes, it takes some strong negotiation skills because you're looking at integrating the culture. And the negative perceptions about MAT within the inmate security, medical, and administration population was large. It was strong, it was big, and it was pervasive when we started. So having the knowledge of what we needed to do, what we wanted to do, knowing what we needed for staffing, individuals, and we had overlooked this in different times in our history, it was really important to develop your blueprint. Like, what's the policy and procedure going to look like? Somebody's trying something new, they don't understand it, it's not part of their culture. They need guidelines. So your policy and procedure development is critical when you're creating something that is not just innovative, but when it's bringing different cultures together to provide the product. So the medication protocols we needed to come to an understanding. There was a lot of education that went back and forth between medical departments. Policy that allowed integration and respected the missions of both entities in order to have buy-in by those that were making it a possibility for us to do this work. We also need to include the accreditation standards. This was really important, and we talked about this one last month, but the National Commission on Correctional Health Care provides the accreditation that SAMHSA will accept to have an OTP in the prison, because having one in the prison does not allow Kodak or an OTP entity to meet the standards of JCO or CARF. We were asked to talk a bit about recruitment. So the recruitment within the Department of Corrections is very, very easy. It's offered at commitment if someone comes in reporting that they are already in care, and it is also available to folks who are not in care but come in with documented history or in withdrawal. The service is also explored upon request for those that have been sentenced. And frankly, word of mouth over the last year, individuals will come in ready to participate in the program with that knowledge. Follow-up in the community. We posted notices in the prison to engage folks pre-release, because we also have an OBOT or an office-based facility on the campus for care with buprenorphine. So we have a lot of folks that simply are discharged, released from the prison, and just walk down the hill. It's Rhode Island has done a wonderful job in terms of coordination that way. And as an OTP, and again, I know that some of you may have already heard me say this, but we all have said enough that we are specialty medicine. We know what the treatment is, what the successful evidence-based treatment is for the treatment of opioid use disorder. And it's important for us to represent ourselves at all levels, from public policy to supporting other physicians in the community, to represent ourselves as that specialty medicine. representing ourselves that way was one of the ways that we were able to have the Center of Excellence located in the hospital, on the prison campus, along with an OTP within the prison. And then for recruitment in the community, it is also nurturing those relationships with the community partners, utilizing health home services, and not forgetting that any relationship needs to be nurtured in order to continue and sustain. We were also asked to provide outcome information. I referenced this before, that our identified outcomes historically and to the present were mortality, and we have seen a 61% decrease in opioid overdose death here. Reentry and community care, we have a 72% follow-up. Individuals that start care in the prison are at 30 and 60 days connected in the community, 72%. That was not an easy thing that number was not easy to get between 42 CFR and some other barriers, transitional population, etc. But one of the biggest barriers, and I thought was really pretty brilliant in overcoming, were all the data user agreements between our state entities. So Brown University is doing the evaluation for this program and got access to PDMP data, Department of Health data, the registry that John referenced relative to methadone treatment, and the Rhode Island Medical Examiner's Office. Outcomes that we want to move into are measuring recidivism, discipline bookings, which I think is quite important because diversion is really part of the culture when you're providing service in the prison. Is, of course, safety and security must always come first. From that perspective, diversion is always an issue. So the more we can decrease the concern and decrease the actual incidence of diversion, the easier that integration is going to be. We want to further demonstrate our retention and treatment because, yes, it's great to have that high percentage. We want 100%, seriously. We want to measure employment. In addition, again, the continue nurturing the relationships within the Rhode Island state oversight entities. I'm giving this first program a little bit more attention because much of what we've done to move this along has to do with systems change, and it's the same principles for the following two that we're going to be talking about: creating the relationships and then nurturing them. So Department of Health has been remarkably helpful in this, remarkably helpful. The Department of Behavioral Health, Developmental Disabilities in Hospitals in Rhode Island has been remarkably helpful. So as they are helpful, we're there for them as well, with data, with whatever, primarily data and education. Continue the education for correctional staff at all levels, and using the team approach for problem solving is absolutely critical in that it maintains buy-in and grows investment. We want to increase the length of treatment episodes in the prison. The only thing that curtails that now are the dollars available for the medicine itself.
The Rhode Island Department of Corrections program, what is most important to know is that, again, it's almost like parallel process, and it's saying that it's important to influence public policy, it's important to keep relationships between the entities and governmental oversight departments, and most importantly, where the rubber hits the road, it is remarkably important to keep all of the providers from together in education, as John has referenced. This slide is simply there for your reference later. It shows the numbers. We're up to treating about 350 people a day in the prison, with a 75% follow through in the community, with a 61% decrease in gap. It's a strong program and it's replicable. It's replicable from a vendor perspective, as I stated. Where we seem to bump into the most trouble as we've been working across the country with different states and different correctional institutions is more with public policy. So the health home model, John has already well described that. We began that, as I said, in 2014, and these are the principles of the health home. And the goal is simply to decrease spending through care coordination and comprehensive patient-driven services. And the only way to do that, that's a systemic CMS goal, that we know that the only way to reach that goal is to provide, comprehensive patient-centered care. The way that Rhode Island saw this OTP health home workflow is that all of these concentric circles are happening at once. So admission and ongoing health home engagement is occurring while others are having health home team services. Those health home team services are complete wraparound services, full continuum of recovery support care. Everything from medical and dental and psychiatric to family care to connecting to the recovery community, housing, education, transportation, which you can see. So it's consistent and it's ongoing and it's concentric. It isn't linear. The action steps for this one were very similar. The differences, and I will be quick here, the difference in implementing a health home system in an OTP is changing the culture within in terms of pulling people out of the departmental silos and bringing the entire staff together as we're adding these new roles and functions and expanding the scope of our work. The second piece is then educating the community to change that perception, which is a stigmatized perception of a center for the care for opioid use disorder as opposed to methadone clinic. This was the staffing configuration for our health home team. And it equals 4.75 FTEs combined here for every 150 patients. Again, staff selection a little bit different. We need really strong communication skills because we're talking community engagement here across the board, but especially engaging specialty medicine and primary care medicine and data wave doctors. Policy and procedure development was critical for this. We always need to include certification standards, accreditation standards, and regulations, but also just recognizing the importance of having your policy and procedure is always something you can change. Often I hear people say, let's pilot this for a while before we write policy and procedure. When we do that, we found that we don't give strong enough guidance. So creating policy and procedure and then changing it based on outcomes really supports the staff providing the new program as well as allows them to be engaged and invested. We found when we went to recruit, we recruited all the counselors in all of the OTPs, Kodak has 7. We had posters and breakfasts that people could come in and see what it's about. It's not one more thing that you're going to make you do, so to speak. And it's an opt-out model, and we ended up with 95% participation, which we thought was quite high for the initial part of the pilot. And I have to credit staff, and that goes back to including staff in the developmental process of this. In terms of, this is just, we do annual patient satisfaction surveys, and we have some questions here that measure engagement, and you can see how high the engagement is. Just the blue and orange lines are strongly agree and agree. The outcomes were what CMS's outcomes are: ED visits, hospital admissions, and admissions to skilled nursing facilities to decrease. And we found that information through the Medicaid claims data, a custom design database, and integration with OTP registration database. I think what is important here is that second item. We, in Rhode Island, for the opioid treatment health home, because we are a small state, we only have, our population is a little over 1 million, and there are 5 opioid treatment programs. Some of them are single, standalone, some have a few buildings. As I said, we actually have 8 licenses, but one's in the prison, so we have 7 OTPs actually. And what we did as a group, we came together as the Opioid Treatment Association of Rhode Island and funded on our own. We funded the designing of a database so that we all put the information in. It has integrity. It's then further enhanced with information from our registration entity in the state, so that when individuals are registered, that information then goes into that database, and it helps us to measure these things very clearly. The third model is the Center of Excellence Specialty Center. This is the direct quote from the certification standards. It utilizes best practices and provides treatment to, as well as coordination care for, individuals with moderate to severe opioid use disorder. I'm going to give you the primary differences between the Center of Excellence and the health home model in Rhode Island. The Center of Excellence provides all the services that the health home model provides. It is a Medicaid designation. In Rhode Island, we've been fortunate that the commercial insurers have also bought into them and provided us bundled rates. We negotiated bundled rates, so all of the insurers in Rhode Island support a Center of Excellence model. The goal was to increase the number of community physicians prescribing buprenorphine. Center of Excellence is all of the services. However, the medication that's used is buprenorphine. So the workflow, which I know that is very similar to that of the health home as well. And someone is assessed, and this simply shows where people go. If MAT is not recommended, clearly we have a set of referral sources for them. Medical intake assessment may lead someone into whatever medication that they may need, or a referral to a different level of care. In a Center of Excellence versus a health home model, the Center of Excellence is designed to be for stabilization. So the bundled rate is only applied for the first 6 months that someone is with the Center of Excellence. The goal is then for an individual to be referred out into the community. The other piece of that is to support physicians through the Center of Excellence has a SAN doc who will provide consultation, and the Center of Excellence assure the primary care physicians or the data wave providers that at any point that someone is facing a challenge, a crisis, or it appears to be destabilized in any way in their treatment, they are accepted back into the Center of Excellence within 24 hours. That allows physicians in the community to know that when that higher level of care occurs, they absolutely, I'm a little thrown off here, I'm just going to use my regular language, that someone has their back medically. They can send someone within 24 hours to that specialty service, and they don't have to worry about the patient's safety because of the configuration of care. Systems change, this was a big one. We needed to educate all levels of oversight around it, all of our internal departments. We've spent a great deal of time in an organized fashion, as Vermont has done, in going out and educating physician groups. And fortunately, what was a big bonus for us here in Rhode Island was we already had the health home model, so that we've been out doing community medical liaison work for over 2 years. And so now we were just adding another layer to expand capacity for the utilization of buprenorphine. Staffing configuration is a little different. One of the most, one of the most different and important components of this is the medical community liaison. That's the glue that allows all participants to know that their needs are going to get met. Remarkably important and often understated is an understanding of and confidence in MAT. Again, the communication skills and community engagement and willingness to develop with the program, like grow with the program, for what we looked for. Policy and procedure, basically the same principles that we discussed before. We anticipated for recruitment, we had anticipated referrals from primary care offices, CDs, and community hotlines. Our actual referrals were from the Department of Corrections discharge planning efforts, reentry efforts, and physicians referring for pain management issues. Because of in monitoring outcomes, we're just measuring number of participants, referral sources, number of referrals to community office-based practices within 6 months, since that was the goal. What is really exciting here is the number of community physicians in the Center of Excellence network of care has doubled in about a year and a half. So this really has been effective in meeting one of the goals. So the takeaways, I think we're doing pretty good here. The takeaways for us are all 3 initiatives require ongoing monitoring with patient, staff, and community input at all levels, obtained at regularly scheduled intervals. We found that waiting for a problem or a bump in the road or a challenge, often the problem has grown to the point that it's going to require a lot more, it's going to be much more costly to resolve and may have had very negative implications. Whereas if we have regularly scheduled ways to measure those, again, investment in education are both enhanced. Has to be in immediate response to a challenge identification, and resolutions need to be shared. And again, system change is organic, really, and requires ongoing nurturing to be sustained. For references, there's a great deal here. So these are just links, and if you download the website, download the webinar here, you'll be able to access those. I want to point out the Change Book, which is a ATTC NIDA effort, I believe, and it was published in the early 2000s. It is a wonderful blueprint for systems and culture change. It's free and it is astounding, and we've used it over and over again. So that's, as you're looking to implement anything new, even pieces of it, it can be for something tiny like changing your opening time to something larger like what we were just talking about. The 2018 ATIP conference, Enhanced MAT in the DOC, is soup to nuts on prison. If you go to the 2016 ATIP conference, you will find soup to nuts on the health home, Rhode Island health home system, and upcoming will be the Center of Excellence. So thank you very much.
Thank you so much, and thank you for finishing off your presentation for us. Sean Brooklyn?
Yes.
We haven't been getting in too many questions in our chat box, so I was wondering, what if I presented you, I wanted to do this with each of our speakers, but what if I presented you with a quick hypothetical? And as you answer it, John, think about it from the care coordination perspective. So let's just say hypothetically, say I am in need of treatment for my opioid use disorder, but I reside on a far-flung, remote, isolated farm, and so I'm very far removed from one of your regional hubs, say Rutland, Vermont. But I am close to my local village, and I have contact with my primary care provider. Walk us through how would that scenario play out in terms of coordinating the various providers, ensuring that I receive the MAT that I need for my disorder. How might that look?
And Alan, may I ask, is the provider in the village or the community a buprenorphine prescriber or not?
let's say that my provider is not, let's say he or she is not a prescriber. So how might that play out?
So I unfortunately have experienced this before the era of buprenorphine prescribing. So I think the first thing would be to have the person make an appointment to see one of the local providers, and to bring up the subject of having an opiate problem. Perhaps they go in and they say, doc, I've been struggling with this for a while. I'm not quite sure where to go. I started off with, say, painkillers for a back injury, and I ended up needing more and more, and now I'm sniffing heroin or shooting heroin, and I'm really scared because I know there's fentanyl. And the provider may have zero knowledge and zero experience, and may say, well, geez, I don't really know what to do. Or the provider may say, well, I have a local treatment relationship with, let's say it's a counseling network, and maybe we should start there by having you go and have an assessment and determine whether or not, they might offer you counseling. And then the patient may say, well, yeah, I've kind of been through that, and what I'm really interested in is being on either, methadone or buprenorphine. What do you know about those? And then the doc may say, well, I don't know anything, or I have a colleague that is a prescriber, and perhaps I can connect you. So I think the scenario can vary depending on the situation, but let's say for the sake of argument, there's no treatment provider for 100 miles, and the patient is somewhat persistent. Perhaps the patient could say, well, I have a friend who's taking this medication, Suboxone, and his doctor prescribes it. He, lives a long way away from here, so it's not an option. I'm wondering if you'd be willing to look into that for me and see if it's something you'd be willing to do. So that's, I suppose, one possibility. The second possibility would be for the patient to walk in and have a very negative experience where the doc says, well, I don't do that kind of thing, and I don't think medication really works anyway. The patient could actually go onto the SAMHSA website and could do if they have a computer, access to a computer in the library, you can do a treatment locator. You can find anywhere in the United States, any provider of buprenorphine that's registered, or even an OTP, it'll come up on the lister. And while it's not complete, it may actually give the patient a connection to call and perhaps begin to work on either getting in with that person or some other situation. The other thing would be to even call the Department of Health of the state. They'll sometimes have a listing of all the prescribers of both methadone and buprenorphine. And then the third thing would be to actually consider the concept of teleprescribing, telemedicine. There are practices around the country. I'm familiar with one, I think based out of California, that has offices around the country where patients can access via telemedicine buprenorphine. And there are some requirements involved in terms of having a face-to-face visit. But that's something we've actually done in Vermont, where we have prescribers who prescribe remotely. They meet with the person once or twice, and then they work out an arrangement where they have weekly or bi-weekly sessions over the phone and over the internet with video capability, and the patient picks up the prescription, and they can even go to a drug testing facility and have testing. So that would be, I think, another possibility for a very rural area if there was no access to any local treatment. But let's say the ideal situation is that, so I guess then, the final scenario is that if the patient walks in and this is a buprenorphine prescriber and they're willing to take the person, but the prescriber has no real experience around counseling or coordination, perhaps the provider himself could reach out, him or herself could reach out to a local mentor, a local expert, try to get some more expertise, and perhaps even take the training themselves. So I think that are some of the different thoughts that I have, and hopefully that gets to the heart of the question.
Very good, John. Thank you so much for spelling out these hypothetical scenarios. Thank you. Linda, let me present to you a hypothetical. It's a similar hypothetical that what I asked John earlier. And when you answer, speak from the perspective, if you would, of care coordination. So let's suppose that I am in the Rhode Island criminal justice system and I'm receiving MAT for my opioid addiction. So could you describe what the care coordination would look like for me as I leave the system and re-enter my community?
Okay, so the care coordination would begin as you are preparing to leave the correctional institute. And that coordination would be between the medical department of the Department of Corrections, the discharge planners, that would be the vendor, or in this case, Kodak, and the community partners. Because as I had said before, in order to have not just a warm handoff, but a hot handoff, it is necessary to have strong care coordination so that individuals, the discharge planners with the individuals who would be leaving prison are contacting the entity to whom that person will be going based on them identifying it's their choice. If perhaps someone has been receiving buprenorphine in the community with a data waived provider, and that person says, look, this is a private practice, I can't see somebody tomorrow, I can give him an appointment in 3 weeks, because we know that release dates, you simply can't pin them down. So what happens to that individual in those 3 week time? This program requires the vendor to be able to provide treatment until they can be connected to their provider in the community. And so there's coordination then between the provider in the community, the discharge planners, peer recovery support specialists that move in throughout that piece and are introduced prior to release. Also Medicaid, we work very closely with Medicaid to assure that when someone leaves, if they are eligible for the ACA, any of the ACA opportunities, that the vendor, Kodak, has a navigator that helps people so they may be activated and actually get that coverage within a short enough period of time that payment can be retroactive. So it's sustainable to say that. A lot of times people think, oh my God, how altruistic. Well, we would probably close our doors if we gave away free treatment, but the way all the time. But the way that it's done is to recognize that there's a great deal of coordination that occurs through the discharge planners to the community, and really the hub, if you will, is the vendor in this. So in this case, it's Kodak's responsibility to be able to go back to the prison and say, yes, Alan has left prison and we're going to continue his care for the next 2 weeks until he sees Dr. Smith.
Great. Thank you, Linda. I think we have time just for one quick question. Let's direct it to both our speakers. So we'll start with you, John. Could you just tell us a little bit about how the engagement of the family or the use of peer support workers, how might that work in your system in Vermont?
So all of the counties in the state have recovery centers. They're mainly peer support centers, and in some of the hubs, they actually send peer support workers to the hub to be near the dosing lines to engage people in a variety of recovery-oriented activities. They may be promoting their center, they may be promoting an outing, they may be promoting a meeting, or they may just be hanging out chatting about how people are doing and checking in with them. We have a fairly robust system called the Rocking Horse Program, which helps women who are pregnant or young parenting and their partners participate in various programs to help solidify the family. One of the things that does occur in Vermont is we are very heavily oriented towards treating pregnancy in treating substance use disorder in pregnancy as a treatable and not a criminal endeavor. And so we will have in each county a program that coordinates the care of the pregnant and parenting a newborn and their families to try to give wraparound services and engage DCF or Department of Children and Families in a positive versus a negative manner. In addition, we have outings and events at various programs for families to participate. So there's never a downside to that in the hubs. And then in the spokes, it depends on the area, but many of the practices are family practices and community involved. So we like to engage family. In fact, some cases we have both members of a couple are in treatment and perhaps even a family member in treatment. And except for the limitations of HIPAA, we try to engage these folks in collaborative work.
Great. Thank you, John. I think in the interest of time, let's now hear some closing remarks from our SAMHSA representative. So at this point, ladies and gentlemen, I'm really happy to present to you Wilson Washington, Jr. Wilson sits within the Center for Substance Abuse Treatment, CSAT. He is a senior public health advisor and has been serving as the project lead for the Behavioral Health Information Technologies and Standards Project, which we affectionately know as BHIS. So, Wilson, the floor is yours.
Thank you so much. I'll be very quick for the sake of time. First of all, I want to thank the attendees and all of our distinguished panel of presenters on their engaging series of care coordination OTP series webinars. And I want to especially thank Dr. John Brooklyn and Linda Hurley for your very informative presentation on the action steps for implementation, providing us with examples. You've definitely given us some insights on how to properly address a very complex public health concern or epidemic around substance use disorders and opioid addiction, especially when it comes to the criminal justice system, successful re-entry into the community, successful care coordination of those consumers is very important. Certainly can mean the difference between life and death. I love the examples provided, the hub and spoke model, the medical home model, the fact that FQHCs are completely conditioned with a lot of resources to be able to manage integrated care delivery, do so very well. The Center of Excellence, and talk around Center of Excellence, and the need for education at all levels of oversight within all departments that are involved, and education within the community. Certainly, patient safety is a huge concern, and so overall, this has been an exceptional webinar series, which started with Care Coordination 101, building a roadmap. Part 2, putting it all together, and certainly ending with implementation or action steps for implementation. I've always believed that the difference between a dreamer and a leader is the action, taking action, and action pretty much is in my opinion, the key hallmark for success. So you all have definitely demonstrated that you're doing what's required out there to handle this very complex public health concern. And certainly on the behalf of SAMHSA, the BHIS and FEI team, I would like to thank you all and everyone in attendance, so especially our esteemed presenters who participated in this webinar series. Thank you for a job well done.
Thank you, Wilson, and thank you to SAMHSA for allowing this very exceptional webinar series to proceed. So with that, thank you for joining, ladies and gentlemen, and with that, we are adjourned. We wish you all a good afternoon. Take care.